Now we are starting chapter 9 with behavior therapy. This is B.F. Skinner and Albert Bandura. So let's start with Skinner. B.F. Skinner has a PhD in psychology from Harvard. He is considered the father of behaviorism. That's a question. He's deterministic. He does not believe that humans have free choice at all. He denies thoughts and feelings cause behavior, and he pays a lot more attention to what is observable behavior. And Skinner is more inclined to watch experiments in the laboratory and focus on experiments. Albert Bandura is also a behaviorist. He was the youngest of 6 children, and he was born in Canada. He got his PhD in clinical psych at the University of Iowa. Albert Bandura is responsible for um, social learning theory. We'll talk a lot more about that in this chapter. He is also someone who really broadened the scope of behavior therapy to include some existential qualities. He wrote The Self-Efficacy, the Exercise of Control about Our Life Choices. His theory of self-efficacy applied to areas such as human development, psychology, psychiatry, etc. And he focused on different areas of research, which were the psychological modeling, the power of psychological modeling in shaping thought, emotion, and action, the, the mechanisms of human agency or ways people influence their own motivation and behavior through choice, and people's perceptions of their efficacy to exercise influence over events, and for how stress reactions and depressions are caused. So make sure you read about him in page 233. B.F. Skinner is deceased. Bandura was still alive when this book was written. He may or may not still be living now. The main thing to remember about behavior therapy is that it focuses on directly observable behavior, current determinants of behavior, learning experiences that promote change, tailoring treatment strategies to individual clients, and rigorous assessment and evaluation. Behavior therapy has been utilized to treat a wide range of disorders and has been used in all different areas and different disciplines, sports, clinical psych, gerontology, a whole host of others. So as we talk about the development of behavior therapy, we're going to talk about 4 areas of development. Classical or respondent conditioning. Some of you are going to remember classical conditioning. Operant conditioning, social learning or social cognitive approach, which is Bandura, what he talked about, right? I was just talking about that, and cognitive behavior therapy. So those are the 4 areas of development. But we're going to start with classical or respondent conditioning. Classical conditioning is really, really important. It's something that I teach or taught in substance abuse and teach to clients about how we're classically conditioned to respond to a cue. So we're going to talk about that in great detail, but just so you know these 4 areas of development, you're going to need to know classical and operant conditioning, social learning theory, and cognitive behavior therapy in detail. In classical and operant conditioning, so in classical conditioning, you're going to need to know the unconditioned stimulus and the conditioned stimulus. And we're going to go over all of that, but those are test questions and test questions on the NCE. Speaking of which, you did fairly well on the midterm, I thought. And there were a couple that I gave credit for today. So thinking that everyone is, maybe it was a good wake-up call, the midterm, but that is very similar to what you might see on in the National Counselor Examination. So getting me prepped, I was pretty pleased with the averages. All right. The classical or respondent conditioning, like I just said, is what happens prior to learning that creates a response through peering. It's going to make a lot more sense in a minute if you've never had it before, because I'm going to explain it in detail and then give you a real world example to make it applicable. Operant conditioning focuses on a type of learning in which behaviors are influenced mainly by consequences that follow them, punishment, etc. So we will go over that in great detail so that you understand that. Great. And can't talk. I should not do these late at night. Social learning or social cognitive approach is just like it sounds, how we learn. The interaction between behavior, personal factors, and environment. And cognitive behavioral therapy is social skills training, mindfulness-based stress reduction, cognitive therapy, and acceptance-based practices, all of which we're going to go over this PowerPoint and talk about when we get back in class. So there's some basic characteristics and assumptions about behavior therapy. There are a set of clinical procedures that rely on experimental findings of psychological research based on principles of learning that are systematically applied. Behavior is operationally defined, overt action, as well as internal processes. Change can take place without insight. Now, who's that different from? And underlying dynamics and origins of psychological problems. So it's not looking for that. So very different than some of the other theories you've learned about. Behavioral treatment interventions are individually tailored to problems experienced by the client. The behaviorist asks what treatment, by whom, is the most effective for this individual with that specific problem under which set of circumstances. Oh, I'm impressed with these slides I did a while ago. These are pretty, aren't they? Aren't you glad just you get some prettier slides to look at and keep you awake? So, goals of a behavior therapist. The general goals of behavior therapy are to increase personal choice and to create new conditions for learning. Measure that progress toward a goal based on empirical validation. These are all empirically validated. And everything is concrete and clear. Your goals are really concrete and clear. Everything is very clear and laid out. Nothing's really ambiguous in behavior therapy. Behavior therapists often conduct a thorough functional assessment using the ABC model. A stands for antecedent, B stands for behavior, and C stands for consequence. The A is the situational antecedent, or what triggered what is occurring, the stimulus. So a stimulus or event that occurs before a behavior in time. The stimulus or event may result in the behavior. Work examples include goals, policies, training, job aids, and guides. A behavior is anything that we can see our individual do or say. Consequence could increase or decrease behavior in the future depending on the reinforcing or punishing properties. Work examples include feedback, recognition, task completion, goal achievement, and rewards. So the Q is A. The dimensions of the problem are B, the behavior, and C is the consequence of the problem, either increasing or decreasing the behavior. The behavior is influenced by previous conditions leading to a consequence. I don't think I wanted to go over that yet. I might want to say more about this. I think I do, because I really glossed over this, and this is super important. This is what I want to say about this. This is the behaviorist ABC model. But in the later wave of the development of behavior therapy, in chapter 10, if you want to look over now, you can scroll over to see Albert Ellis's REBT framework, rational emotive behavior therapy. So it's a form of behavior therapy, but it's based on this ABC framework. And that's what I was wondering if I had a slide, but I think I'm trying not to confuse you or get too far ahead. However, if you've heard of that model, it could be confusing if you just read this. He took it a step further to say A is the activating event for the interference, C is the emotional and behavioral consequence, and B is the person's belief about A, which creates C. The therapy comes in the D and then the E. And the D is the disputing. You're disputing, detecting, debating, and discriminating those irrational, self-defeating beliefs so you can have an E, effective new philosophy. It's called the ABC framework, and it's ABCDE. And it makes a lot of sense, and it's super powerful, and all of you will need to know how to do the ABCDE model because it was super, super helpful. And it's the basis for cognitive behavioral therapy. So this is where it started. So if you want to get the base of what's going on, here we are. So make sure, get a feel for that and understand how that works. I think you can understand we have a stimulus that causes behavior and a consequence from the behavior. And usually that consequence can increase or decrease behavior. So it makes a lot of sense. It's valid and reliable, and behavior therapy kind of rocks. You can tell I'm a little bit of a behaviorist because I'm an EMDR therapist, and I threw it in this chapter for some reason. I'm not. We are a hodgepodge, but I like that I have a lot of behaviorism in what I do. So relationships always important, no matter what. They recognize the role of the relationship as a critical factor. Um, we have to make sure we have engagement with our clients, no matter what we're doing. So back to those 4 areas of behavior therapy. Remember classical conditioning, Ivan Pavlov. Remember that. Some of you had undergrad psych, so you know this, and this is a review. For those of you who did not, this is really, really important. Like my dog here. Ivan Pavlov, he had some dogs, probably a lot of dogs. There's another good story I have about his dogs. But he would conduct experiments on the dogs, and he would bring the food, some steak or something, I don't know, it was a long time ago, and he would ring a bell, and he would bring the steak and ring the bell, and bring the steak and ring the bell, and the dog would salivate, smell the steak, and be hungry and want to eat the steak. And then eventually he did that several times, and then Ivan Pavlov would just ring the bell, but he would not bring the steak, and the dog would salivate. Meaning, after the dog has been classically conditioned to respond to the stimulus, which is bell, bell rings, dog salivates. Now, why do you care? You care because it makes a whole lot of sense when we think about our trigger response and our craving response in drugs. The same thing happens to us like Ivan Pavlov's dogs. So we start to associate multiple cues in our brain and become classically conditioned to want to have our methamphetamine, whatever it may be, right? And it does the same thing, and we salivate. We crave. The craving response goes on in our brain, like we're going to get a treat. And so we have to reverse classical. You can extinct. This can go extinct. Oh gosh, am I saying the right word? There's actual different terminologies for this, and I make sure I'm telling you the right word for that. But we can actually extinguish, I think is the word, this bell response over time when we recondition the brain to respond to a different stimulus response. So in drug court, I would teach this very thing, and I would talk about the dog, and I would tell the story, and I would try to make it really fun so they would understand, and they got it. Interestingly enough, Ivan Pavlov's basement flooded at some point, and all of the dogs got trapped in there in freezing water. It was really scary, and they didn't die, but they couldn't get out of the cage. And when Ivan Pavlov opened the cage, they wouldn't leave the cage. Chew on that. I'm sure you can figure it out, but that's where we started to get our theory for learned helplessness. Right? If I stay shocked in a cage over and over, or I'm going to die, I will give up eventually and just stay in the cage. Also, you notice the different personality changes from the experience. Some were aggressive and some were docile and some were okay, different responses. So really interesting stuff from the body keeps the score. In classical conditioning, extinction occurs when the conditioned and unconditioned stimulus are not paired, just what I was talking about. And the dog's like, where is my steak? I am tired of hearing this bell, and I am not salivating because I know that you are not bringing me a steak. So that's extinction, what I just said. Yes, I was right. Extinguishing it. Gosh, guys, I should not do these. I ran out of time, so I'm doing it at night, which is the worst time. Late, which is the worst time for me to do this. But hopefully, I am somewhat entertaining. So that was classical. Okay, it's involuntary response to a stimulus. It happens. Operant conditioning is associate a voluntary behavior and a consequence. It's instrumental learning. It can be positive and negative reinforcement, punishment, or aversive control. So I talked about extinction already. With ringing the bell and not getting a cheeseburger or the steak. But all reinforcers tend to increase the probability that a behavior will occur. So they are different. So let's go over all of those because that's the difference, right? So you see the mouse trying to get the food, and the bell, and the involuntary is just the salivation. But the actual mouse is trying to get food that's operant conditioning. They're conditioned to get the reward. This operant conditioning is what we do to children in schools and what we use in drug court. It's like a token economy. We are giving rewards and punishing, withholding, and etc. So they all have a different definition. There they are, and we're going to go over each one of these, and then we'll go into social learning. So just as you recap, remember we talked about moving through these 4 areas of development. Let's just really quickly look. Classical or respondent conditioning, number 1, that's the Pavlov's dog, involuntary response. Operant conditioning, that's like drug court when we gave them tokens and rewards or withheld or put them in jail. We're about to talk about that. Number 3 will be what we talk about in just a minute after we talk about operant. That's social learning or social cognitive approach. And then we'll finish up with a nice round cognitive behavior therapy. Hope you're still awake. Hope you're more awake than I am at this point in my life. Where we go. Operant conditioning. So positive reinforcement is the addition of something the person values. And you need to know this. Boy, do you. You'll get a complex question on the final, or you're going to get a complex question on the NCE or CPCE, which is why my midterms and finals are a little bit tricky at times. They're not terrible, but they do cause you to really think, as opposed to the reading quiz. It's a little bit easier. So, but the positive reinforcement is addition of something the person values, like praise, attention, money, or faith. Okay? So that is like in drug court, we did a star. And if you got the star, you did everything right. And you got your money, your name, and the chance for a raffle ticket for like $50 or something. And we would draw that. The more positive tokens you got, the more opportunity you get to get the name in the fishbowl to get a prize. Negative reinforcement is escape or avoidance of aversive stimuli. So see how that's different. It's not the addition of, it's escape. We're avoiding going to jail. Avoidance of an aversive, of a not a nice stimuli. You do not want to go to jail. Nobody wants to go to jail. I don't think. Maybe some people, but extinction. Withholding reinforcement from a previously reinforced response. Temper tantrums, right? So if we don't respond to the temper tantrum, that behavior may be extinguished, right? Because we're not going to reinforce it. Punishment is consequences of a behavior that result in a decrease in behavior. So it's not an avoidance, it's a consequence. Positive punishment is aversive stimulus is added after the behavior to decrease the frequency of the behavior, such as a timeout. Now, I know, read it, memorize it, write note cards, because I understand that it is a little bit confusing, but once you get it, you get it. Give yourself something that just makes you remember it. Sometimes I used to do funny little rhymes and things to make myself remember these things for my test. So if you're having trouble, just try to come up with something to help you remember it. Negative punishment is a stimulus is removed following the behavior. Aversive stimulus is added after behavior, or something is removed following the behavior, like taking your iPad away. And which one do you think works the best? Oh, no one can answer me, right? So fun talking to my computer by myself at home. So fun. I'm wondering what you think. We do find that positive seems to work best. So basically, if I can catch my child doing something positive versus always punishing the child and giving them praise when I catch them doing something right, that reinforcement causes that behavior to be demonstrated. That was not what I was looking for. So we know that positive reinforcement seems to work best even in drug court, and the outcomes were far better with that type of response. So memorize those, read them, make your note cards on 241 and 242. Hopefully my examples help you put those into perspective. And then we have social learning approach. We have classical and operational model. The classical and operational models did not reference the role of thinking, attitudes, and values. What do you think this is? Okay, starting over again. So, social learning approach. I just asked this question, I think, when I was recording last night, but classical and operational models, they do not reference the role of thinking, attitudes, and values. And why do you think that is? And just think about that because we've gone through the first two examples, reading the text as well. And then we have Bandura, who we talked about when we first started the presentation. We saw his picture. He involved more self-efficacy, and he created a triadic reciprocal interaction. So triadic is three, each influencing the other: environment, personal factors, and behavior. Personal factors are beliefs, preferences, expectations, and self-perceptions, and behavior. How are the events in your environment interpreted by you? Which is ABC model, right? The basic assumption is that people are capable of self-directed behavior, and that you're in charge of change. So this has been proven that we socially model after others and also used in substance abuse treatment. We would talk about the different models of learning that clients would experience. So they may have learned drinking and smoking and other behaviors or drug use from their from their family of origin, from media, from movies, etc. A friend group. So it's a very, very powerful approach. Also, there is systematic desensitization. It's probably something that most of you have heard about in your work prior to even becoming a counseling student. And it is how you actually reverse classical conditioning. We become classically conditioned to certain things, triggers, and this is what EMDR does as well. We become classically conditioned to have a panic response when certain things in our environment trigger us that remind us of the original event. And so that is exactly what we're doing in EMDR. We're reversing classical conditioning and we're extinguishing the fear, the trigger, the brain. That's one thing we're doing. We're also installing new positive beliefs, etc. So this is a behaviorist approach. It's very, very powerful. All of you can use it immediately. When there's something that you want to reduce the fear or aversion to, you slowly introduce them to the snake, spider, etc. Spider is a good example, but you create the fear for each behavior, and then you titrate up in helping to treat an anxiety disorder regarding a stimulus that's triggering for the client. There is a three-part process to systematic desensitization. It involves relaxation training and the development of that graduated anxiety hierarchy that is here. In systematic desensitization, through presentation of hierarchy items, while client is in a relaxed state. So essentially what you're doing is relaxing through things like progressive muscle relaxation, which is what we will do when we're in class. We will do that activity, but you can practice it for yourself. It's a wonderful activity where you tense and let go of each muscle group. And so you can apply it on yourself and on your clients. So you would get them in a relaxed state before you do this. And that's very similar to what I'm doing in EMDR now when I do the meditation. I meditate and then go into the traumatic experience. And then I also use something called the flash technique, which is the subliminal message to the brain. So I put them in a relaxed state while having them put the upsetting event into a box. And then I have them blink. Don't try this at home because I actually gave myself a phobia when I was practicing it at a conference because we did it wrong. And I was with Shelby and Greta. And Shelby and I, Anyway, we did it incorrectly. We reversed it. So we actually gave ourselves a phobia and then we took our phobia away pretty quickly. But I think it was a good lesson on how powerful it was. It scared me so bad that I didn't use it for a year until I got more training in it because I didn't want to make anybody worse. But and then we go in that relaxed state to the memory, which is now more distant, and then we use a bilateral stimulation to reduce distress, and essentially we're desensitizing the memory. There's the science, some of the science behind EMDR, and I think sometimes that makes more sense. I'm going to bring my EMDR machine, or I think I am, next week so we can play around with it some. All right, I think I've already said all this. It is empirically validating and it's time consuming to do systematic desensitization, but it's work. It works and it's pretty powerful. So here is, I think, a dog exposure activity. So you know how to do it. Here are the 3 steps I just talked about: relax, hierarchy, and then presentation of hierarchy items while in relaxed state, neutral scene, then anxiety provoking scene. Homework and follow-up, gradual exposure to real life, and then the first step is usually muscle relaxation that you use in the relaxation training. Now we have, so that's systematic desensitization, but there's also in vivo and flooding. In vivo is where you actually go to the anxiety evoking events rather than imagining them. That's in vivo versus systematic. Flooding is in vivo or imaginal exposure to anxiety provoking stimuli evoking for prolonged periods of time without the fear of consequence. So we're essentially flooding the person with it. EMDR is an exposure-based therapy. It involves imaginal flooding, cognitive restructuring, and the use of rhythmic eye movements and other bilateral stimulation to treat traumatic stress disorder. It treats a whole host of other things as well, but it's been really validated with PTSD, which who doesn't have symptoms of PTSD? Pretty much everybody has symptoms of PTSD. But also, bilateral stimulation is bringing both hemispheres of your brain on. So it's bringing the left and right hemisphere on. You do not have to use eye movement. I use bilateral tappers in my practice because clients often like to close their eyes when we're processing. It's very powerful, and it is a very, it's interesting to me that they threw it in behavior. It is behavior-based therapy and it is based on science. But it is also CBT and mindfulness. And so those are all behavior therapies, but it's also psychoanalytic, some Adlerian, and some existentialism as well. So it is a really nice, I'm trying to say here, blend of different therapies. I will go over it in more detail in class. I've got that on my list to do in class. You're going to read about the controversy with the eye movements. There's a lot of really good literature that proves that this works. And there's some that say that eye movements don't matter and some that say they do. I would say it's up to the client. The client is comfortable and that's what they want. So we're good. Here are the 8 interweaving phases of eye movement desensitization and reprocessing therapy. You take a history and get to know your client here. You prepare them by preparing them and educating them. And I mean, I pull out research and we get online and I want them to go research it. I want them to be comfortable. We sign a different informed consent. I educate, and I prep. So we do lots of preparation. We do lots of coping mechanisms where we install those in the brain. And then we do our assessment phase. So we've prepared, we've written our treatment plan. Then in the assessment phase, it's assessing the memory. So you're going through this protocol. You're actually asking questions before we desensitize it. So I'm asking them, what is the most disturbing part of the picture? What picture do you get when you think about it? What words go best with that picture that expresses your negative belief about yourself now? What words go best with that picture that expresses the belief you wish you could have, would want? How true do those words that are positive feel when linked with the original event. Usually don't feel really true. That's a validity of cognition, a VOC. Very detailed therapy. The validity of cognition 1 to 7 usually feels false. My goal is to get that positive cognition linked with memory. See all the behaviorist qualities here linked with memory, with positive belief feeling very true. That's my goal for ending. Then I ask what emotions, when you think about the memory and the negative words, say, I'm not good enough. What emotions are coming up for you now? When you think about the memory and the words, I'm not good enough, how disturbing is the memory from 0 to 10? 0 is no disturbance, 10 is the highest. That's a subjective units of distress scale. That's a SUD scale. When you scan your body from head to toe, thinking of the memory and the words, I'm not good enough, or something else, where do you feel it in your body? Because we usually store trauma and upsetting life events in our body. And they usually feel it in the solar plexus, gut or chest. And then we actually move forward into the desensitization phase, which is the bilateral stimulation of the brain. I do lots of different things because I've been trained for so long. I create protectors and I use parts. I do parts work. It's very intricate. I do attachment therapy. I do imaginal mother father. I may have done all of that before I do this. Then we actually start desensitizing. I may have flash techniqued it and I may have meditated with them before we do that. So I would meditate and do the assessment and then desensitize. So you see how I'm putting them in a relaxed state. I didn't always do that. In fact, I kind of got trained on not doing that. And now it works way better like that, I think. And we rock on like that for a long time, maybe like 40 minutes or more, an hour and a half, depending on how long it takes. If it's a first memory, earliest memory, or the worst memory, it could take us an hour and a half or more, which is why I now do this therapy for 6 hours. I offer it once a month, and people can contract with me for the day, the whole day. And I do 6 months therapy in one day. All right. And then when we have completely desensitized the memory to 0, I want a 0. I don't want, when they think about that memory, I want them to be a 0. I want them to completely reversed. I want it to be extinct, any emotion or negative thoughts. And that might seem strange, but I'm going to explain it to you when we're together more in detail. I install the positive belief. The positive belief should feel very, very true, like a 7 on the VOC scale. We scan their body from head to toe, making sure there's no body disturbance when I make them think about it. So I bring them back, think about the bad thing, think about the rape, think about the child abuse, think about it in the words, I am good enough. Where do you feel it in your body? I don't. Good. Then we install the body feeling, that it's a good body feeling. And then we close by recapping what that was like and talking about the next week. So that's how it works. I'm probably going, what? That was way too much. Okay. Also, in behavior therapy, we have social skills training. So there's so many things that you would probably use right when you go into practicum and internship. This is when you help clients develop and achieve new skills in interpersonal dependence, like assertiveness training. It may involve behavioral techniques like psychoed. So psychoeducation is an actual intervention in behavior and CBT. We're actually educating the client about 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 behavior therapy and about assertiveness or about anger management. Then we do modeling, which is the way we model in the session and behavioral rehearsal, and they rehearse and they get feedback. If clients can correct their problematic behaviors, then they go in practice and they can do it in real life, and then they get practice in real life. We also have self-management programs and self-directed behavior. So these are self-management assessments and interventions. The theory is that we can help people change if we teach them how to cope in situations that are problematic for them. So things like helping the client set goals and translating those goals into target behaviors, how to create an action plan and then self-monitor themselves, evaluating their actions. So you can think about, you've probably done this or done or read a book or seen this laid out in your own life. There are some basic steps laid out on page 249, 1 through 5, and you can take a look at those. These can be used for things like helping children cope with the fear of the dark or managing your anxiety in social situations. Then we've got multimodal, and then we've got mindfulness and acceptance. So this is Arnold Lazarus, another name that you need to know and you need to be familiar with. He created multimodal therapy. It's a type of behavior therapy. It emphasizes the whole person, and it's grounded in social cognitive learning theory. There's an assessment piece that's multimodal. The different modes are all the basic ID to the right are the different modes: behavior, affect, which is feeling, sensations, images, cognitions, interpersonal relationships, and D is drugs, biology, nutrition, and exercise. 7 areas of functioning. That's the multimodal. Sometimes I think in this field, we just give all these names to the same thing that other people are doing, but this is like biopsychosocial to me. And it's also EMDR on steroids. I mean, the EMDR is on steroids compared to this, but this is exactly what we're doing in EMDR. Um, but the therapist, you look at those 7 areas of client functioning based off the basic ID. You need to know that. You need to remember basic ID. Remember who that is. Lazarus. To study for this section, I would perhaps make note cards of each. Go through your book and write out multimodal, mindfulness, systematic desensitization, social skills training. I mean, write everything out and then on the back put some bullet points about any theorist or anybody that's connected to it so that you can memorize it and know it, and and then you can keep it for when you're studying for your CPCE and NCE. There's a book that you're all going to get to study for that. It's a purple Rosenthal book. I know we've talked about it, but we'll talk about it again. Um, and there's a theory section, and that is a really fantastic way to study. But also, if you want to make note cards for each chapter about the different interventions and what goes with which theorist and what kind of terms go with the theorist, that might be a really quick way to study and something you can use for your reading quiz and your final examination. A multimodal therapist, they're very active during the therapy session. They're trainers, educators, consultants, coaches, and role models. They provide information, instruction, and feedback, as well as modeling and assertive behaviors. Offer suggestions, positive reinforcements, and appropriately self-disclose. Suggestions are not advice. They are related to the therapy. So homework, activities, things such as that. Okay. Mindfulness and acceptance-based approaches. Yes, they're evidence-based. Everything in here is. Emphasizes the limits for behavioral therapists. Include mindfulness, acceptance, therapeutic relationships, spirituality, and values. There are 5 interrelated core themes. They are psychological health, acceptable outcomes in therapy, acceptance, mindfulness, and creating a life worth living. So these are 2 approaches. So there's mindfulness, acceptance, and then there's mindfulness-based stress reduction, mindfulness-based cognitive therapy, and acceptance and commitment therapy. And I would do what I said and write note cards so you don't forget. These are the 3rd wave of behavior therapy. Okay. Remember back in the beginning, did we go through these? These are in the 3rd wave. I'm going to say, I'm going to go back. You guys are probably getting annoyed with my crazy moving around. Okay. What do I want to say about this? Very recent: mindfulness, acceptance, relationship, spirituality, values, meditation, being in the present moment. Um, so these new age, third generation behavior therapies, they are focused on these 5 themes. So this is just making sure that you understand the backing of it. So here are the themes. And it gives you the definition for mindfulness and acceptance in your book. Mindfulness is the awareness that emerges through having attention on purpose in the present moment. You've done that with me in class, so that's easy to remember. And not judging. And acceptance is the non-judgment. It's a process involving receiving one's present experiencing without judging or preference. There are 4 major approaches. Man, I did a really good job on these slides a long time ago. Good for me. Um, 4 major approaches: dialectical behavior therapy, DBT, probably heard of that, great with borderlines, mindfulness-based stress reduction, mindfulness-based cognitive therapy, and acceptance and commitment therapy, which is ACT. So let's take them out. Let's talk about them. Now I'm doing this really early in the morning, and I was doing it late at night, and I'm not really sure what's better. But I do think I'm going to refill my coffee because I think that might be helpful. I'm going to pause you guys for a second. Okay, I'm back with coffee and I had breakfast, so maybe that will help me. DBT is originally created for treating chronically suicidal individuals diagnosed with borderline BPD. Very important for you to know, borderlines often are suicidal. This is doing terrible to say this, but often will actually complete suicide because those behaviors are attention seeking, and not in a bad way. They usually have a high comorbidity with trauma. I have a lot of borderline clients, so I like them. They're tough, but I enjoy them, and I kind of know I have a kind of a method to what I do that works, and those symptoms seem to dissipate over time when we deal with the trauma. But they're trying to get a need met with the behaviors and the self-injurious, and not everybody who has self-injurious behaviors. There are a multitude of different things going on for people who have self-injurious behaviors, which is cutting. It can be anything. It can be stress. It can be modeling after others, social modeling. It can be saw in a movie. It can be depression and anxiety. It can be anything. So it's not just borderline, but often those behaviors in borderline client, they're trying to get a need met. They didn't get their needs met as a child, and they're suffering. Um, they're suffering, and what they end up doing is pushing people away with their behaviors. And they have eating disorders, suicidal ideation. I just said non-suicidal self-injury. And DBT, it treats a lot of things, but it effectively and based on research treats borderline. It definitely helps people cope. Um, Validating where they are, meeting them where they are. Um, they didn't have what they needed as a child, and now they're trying to get it in maladaptive ways. That's the way I can describe it. Um, Sometimes I like to tell you about stories, just because I have a client who was very off-putting and would get very angry with me, but that's how she felt like she got her power back. And I stayed and didn't abandon her. And the very act of that was enough to start change for her. I think I talked about that some in class already. So DBT has acceptance and change-oriented strategies. Um, they teach the skills in 4 modules. So mindfulness, interpersonal effectiveness. How are you effective with people interpersonally? How do you regulate your emotions? And how can you tolerate distress? Those are so valuable for someone who has trauma. So DBT is amazing. Guess what? All of you can get trained and start doing it right away if you want to. So these are things that you guys can utilize. You need a little extra training for this, but you can find a workshop or find something online. I think I think these strategies in the behavior therapy section are phenomenal. You know, I'm EMDR, and we know that Dr. Powers is CBT. So in mindfulness, so you've got two professors who utilized a lot from this section, the next two chapters. I would say some of the most important that you'll learn are these two and Dr. Muller's family therapy class. So mindfulness-based stress reduction is a form of psychotherapy. It's not a form of psychotherapy, but it can be an adjunct to therapy. Helps people live more fully. The skills taught in I can't ever say that, MBSR include sitting meditation, mindful yoga, aimed at cultivating mindfulness. Now, mindfulness-based stress reduction is taught all over the place in every walk of the sun. And when we're back together, we'll do the egg of light meditation. Okay. There's also acceptance and commitment therapy, again with the note cards. This is called ACT, and it's another training. You do have to get trained in this one. Um, I mean, really, you need to get trained in all of them, some extra training. I think between Dr. Powers and myself, we can train you in mindfulness enough for you to start using it. But EMDR, of course, has a very specialized training. You cannot use EMDR unless you have the training, which is 72 hours. Well, I say 72 hours, it's 3 full days in a textbook to read before, and then that supervision after. So it's pretty intense. Okay, if ACT, they have these trainings sometimes. It involves accepting present experiences and mindfully letting go of obstacles. There is little emphasis on changing the content of the thoughts, but the emphasis on accepting. So this is that mindfulness piece. We talked about when I'm teaching you about mindfulness, when I just accept in non-judgment the thought that comes, and this is a piece of this therapy. And that's why we started with the definitions of acceptance and mindfulness. And it uses acceptance and mindfulness strategies to increase psychological flexibility. The more we can do that, the healthier we are. All right. We made it. We made it, guys. This is a long one for me. Hopefully, you don't get bored. Shortcomings from a diversity perspective. Some counselors may use a variety of techniques in narrowly treating a specific behavioral problems. Therapists who do not assess the interpersonal and cultural dimensions of the client's problem may not adequately prepare them for the consequences of newly acquired social skills. That I can talk about a lot. Being very cautious about what's happening. These therapies are powerful and they change people's lives quick. And you got to think about culturally what that might mean for somebody. Sometimes lots of education before you go. That's why I spend so much time educating my clients and making sure they sign a new consent and they know exactly what they're getting into. And I tell them I'm not popular with families because, especially my clients who are people pleasers, they stop doing that. They're not people pleasers anymore, and that's one of those behaviors that are affirmed by others that are really negative for us internally, but look really positive on the outside and get us accepted and accolades. But in reality, it just destroys us inside when we're people pleasers. So my clients start to say no, and what does that counselor do? Anyway, heavy focus on behavioral change may detract from clients' experience of emotions. Yes, but most of these third wave therapies, they're very Rogerian as well. So, some counselors believe the therapist's role as teacher de-emphasizes relational factors, and behavior therapy does not provide insight. That's not true. But whatever the textbook says, Dr. Veal says, that's not true. I can't. The insight from an EMDR session is like nothing you could ever imagine. The insight that you get from my own work that I've done on my own self, unbelievable. I can't even talk. It's so crazy how much insight people get. Okay, limitations and criticisms. Behavior therapists emphasize changing current environmental circumstances to change behavior. Behavior therapy recognizes the importance of making the social influence process explicit. These are the positives, right? Just seem like the limitations and criticisms. I'll have to look at this again. I'll have to look at this when we go into class. I think that might be strengths and it just has a wrong label on it. Yeah, these are the strengths, guys. These are the strengths. My bad. You have shortcomings from a diversity perspective. These are limitations and these are strengths. Okay, I did it in 50 minutes and hopefully sounded a little bit better after I had the coffee. All right, read, notes, accept.